and do as the instructions said. You basically read the case, give me a DSM-5 diagnosis, list as best you can out of the case the specific criteria that would indicate what level, be a mild, a moderate, or severe use disorder. From there, based on your best judgment, and what we're going to talk a little more about ASAM before we do all the cases. Give me what you would recommend from the standpoint of the patient placement case criteria, and any other, based on the case, any other suggestions based on what it might take if the person may seem to have more resistance or whatever, what needs to be addressed, at least from the management standpoint, what we call the management team of report. And, you know, put those, there's a sheet that I provided for you. Put your case numbers down, and you can put them all together if you want to, and it doesn't matter, and just, you know, submit them, and I will begin to look over them. And everybody has to be honest with you, I guess y'all would be grateful that I'm going to have one hell of a week this coming week, but by tomorrow evening, whenever I know y'all are working and have other things, so I won't look at them till Tuesday. And so you take the first 5 cases. Rebecca, I have a fax machine, and I'll give you a fax number, but it's not something that is commercially used. So, you know, yes, you can fax them. Email is better, but I can give you a number. But I don't have, it's not a large machine, so sometimes it's not, I don't use it except for very small things. So, and I don't know how many pages you'll have. So it's one of those things. So if you could email it to me, I would much prefer that. But anyway, if you want a fax number, email me, and I'll send you that fax number. Okay. But anyway, that'll maybe reduce some of your load, and we can get this done and meet the criteria that we need to do for the course, because that's one of the things we had to do as cases. Okay. Eddie, y'all are clinical psychologists, and I know some of you can be very wordy, which is not bad. ABC, accurate, brief, and clear. My evaluation of what I'm trying to do is for you, especially some of you that are not as familiar with this as others, but it gives me an idea that at least you looked at the criteria, you saw what the criteria looks like, and I'm going to go over some cases with you to kind of give you an idea about what I'm looking for. And so maybe by the end of the session, you'll have a better idea about how you want to answer the questions. And I say I have a lot of work in course prep to do, so I want to make sure it is enough without killing me. I don't want to kill you. I don't want to kill me, because whatever you write, I have to read. And y'all, you know, this is the preparation prep course. It's to get you ready to pass the national board exams. The reason I'm route the cases this way, I think it helps better for you to be prepared for cases that they may have on the board exam and what they probably may ask. All right. I'm trying to get to the chat so I can see your question. I had a separate question there. Some self-assessment questions at the end of the opioid PowerPoint. Will you be providing the answers to those? Now I have 2 different opioid PowerPoints. Which opioid PowerPoint are you talking about? Because I know I have a lot of questions. Okay, I'll look at those, and I'll put together a packet of information for y'all to do it. The one that we did today, slides 128 on. Oh, you're talking about the ones that the slides that we didn't cover, the questions? No, Rebecca. We don't talk about it. If I don't say it, if I don't mention it, you're not responsible for it, even though you will be responsible for it possibly on the final, your national exam. But as far as me, no. Yes, I'll put the answers to those, but I won't post those immediately. That will be something, like I say, I'll have to get me some time to be able to do that. So it's not something I've got to post your exam first, and I'm almost done with it. And that your exam, I might as well talk to you about your exam. 25 multiple choice questions over the materials, and should be pretty straightforward. It should not pose a problem, at least in my mind, because it's fairly simple. It's questions that most people would know anyway, but it's not something that you need to spend a lot of time worrying about. But anyway, we'll work on that. So yes. All right, let me get underway here, because if I don't, we'll never get done. And I do want to get done. I do, because as much work as it has been for you, it has definitely been a lot of work for me. And so we're trying to get this done. So I got this. All right. I'm going to go into the second opioid PowerPoint, but a lot of it is regurgitation, reinforcement. So I'm not going to cover those slides. I'm going to try to highlight some slides that I think are important, and maybe some questions that may be on the board exam. So I'm going to kind of hit and skip and hit and skip. I'm going to do this. I got about 20 slides in this particular presentation. Then I am going to cover safe medications in recovery. We'll cover that entire slide set. And when we do that, after that, then we're going to do cases. And as long as we can work on cases, that will take the rest of our time. And we'll see what we can get done. Okay? All right. Y'all been a great class so far. I just need to tell you that. I appreciate your efforts of getting back and asking the questions you're asking, because I know they're all important. And I'll do everything I can to provide. By the way, I do plan to post the medical cannabinoids section. Also in the resources, I also plan to cover the trauma. Some people ask me about the trauma resources. I'll post those under separate headings. And these are supplemental information. This is not testing information. It's stuff for you and your practices, stuff that I think you might want to use and may be beneficial to you as you move forward with your patients, and might be helpful. So anyway, I'm putting those resources together. I'll send them to Aiden. I've already mentioned it to him, and I'll send it to him, and he'll probably post it in the next few days, and y'all will have that. You also have additional resources on the Moodle webpage that are, again, supplemental. A lot of that information is the evidence-based medicine that is behind the slides that you're seeing. It's a good question. Will the recorded class be available for review this week? I would assume so. I don't know how long it takes them to upload. It's being recorded as we speak, but I don't know how long it will take them. Again, you can email Aiden and ask that question. He can probably give you a better answer than I can. I'm not sure how long this particular application, it's pretty quick. And so he's very, very fastidious in when it comes to putting things together. And so it is, well, if you clicked it on yesterday's link and it worked, then it's probably at UGA, when we record something on Zoom, outside of just uploading and posting, it's almost instantaneous. So I would assume these will be ready within the next day or so. Okay. Because I've also asked for a copy of the recordings. I want to look at the recordings and see where I can make it better and how I can reduce some of the volume. There's a lot of volume of material here within 2 days. And it's hard for me to wrap my head around, if someone comes in and hasn't had a lot of background in this, how they wrap around all of this in order to prepare to take a quiz in order for you to, pass the course. And so I'm trying to consolidate it. But anyway, we'll see. But if y'all have questions, you got my email. You got my email, y'all, and some of you have been able to text me on the phone, and I'm pretty good with that. I respond pretty quick if I'm awake. Now tonight I'll be going to bed early because I've got an early and a very long day, several long days. So as soon as this class is over and I can get out of the office, I'm probably going to go down for the count. But the thing about it is, anyway, if you got questions, send them to me. And I'm an early morning guy, so I usually get up and get back with you as soon as I can, okay? All right. Well, let's talk about a little bit about why heroin is so deadly. And this can apply to a lot of the high-dose opioids. Heroin and its metabolite, 6-monoacetylmorphine, 6-MAM. I want you to know about 6-MAM because it is a metabolite of heroin. It will cross the blood-brain barrier, as I mentioned to you earlier, about 100 times faster than morphine. And this rapid diffusion is due to heroin's high solubility in lipids, And so it's one of those things. Heroin's short-term effects will last over a period of 3 to 6 hours, but it will create pinpoint pupils. It creates, a lot of individuals, nausea and vomiting. It can create constipation and explosive diarrhea. Creates urinary retention due to the activity in the GI sphincter and muscle systems, plus anticholinergic activity, dry mouth, and blurred vision. What happens that creates the problem is there's depression of the medulla oblongata that creates a bradycardia. And bradycardia is, by definition, is usually a heart rate below 60 beats per minute. Your average beats per minute. Some of you are very good athletes and y'all have beats below 60 because of good athlete, but a lot of people have heart rates between 72 to 82 and abnormal low respirations, and those are less than 8 minutes. And so what happens is that those individuals continue to increase the dose, and eventually will get a respiration rate of less than 3 or 4. Heart rate will continue to decrease. And what happens is simply the brainstem shuts down the breathing apparatus, and the heart can't get oxygen, and the person simply overdoses and dies. But I throw this in here because this was a study that was published in 2001. We have had an opioid epidemic for soon to be 50 years. I mean, this is a 40-year follow-up study from 56 to 96. And it kind of gives you a breakdown. And these were hundreds of thousands of individuals. Of the individuals that we see that happens when we have opioid use disorders in our general population. As you can see here, 48% in this particular study die. There's a 12% figure that's unknown, and I would assume that half of that could be that those folks may have died also. But the thing about it is we don't know. But I'm going to tell you that out of the people who develop use disorder, over half of them is estimated in this study to die. So that means we have an LD 50 of 50, which is horrible. Now, if we look at the ones that end up being incarcerated, you can break that down into 4%. You look at the daily use of opioids in this study, it was about 7%. You get the ones that were involved with methadone maintenance. As you will look at the dark line, it is a 6%. You have an occasional use, people who socially use opioids, which is in this population, was about 2%. But the one thing I want to see is that in the abstinence, there was over 22% of individuals. So yes, they had a high death rate, but also they had a pretty high recovery rate. And if you add occasional use and methadone maintenance and incarceration where those people are living, you also see that you have 13, 15, you have about a 40% chance of surviving, or these people were surviving an opioid use disorder. So I think it's pretty important that, you know, if we was to do a study similar today, even with the hundreds of thousands of people that died, we still have an opportunity to treat them and also to get them better. And again, as I said many times before, and as I told you yesterday, our goal, or my goal for my students and for myself, is to make sure I try to make sure that the patient that I have in front of me lives to tomorrow. And that's an extremely important component. We talked about the brain regions and the prefrontal cortex and the nucleus accumbens, the VTA, which are it's your reward pathway. And so I won't regurgitate that. You can look at the slides again and again about the prefrontal cortex and nucleus accumbens, the VTA. We covered that yesterday pretty well in depth. And we talked about the changes of, again, the review of the changes in the substance use disorder, changes in the opioid receptors, the endogenous peptide system, the cellular membrane, the dopaminergic pathways, and the brain-derived neurotropic factors. All of those change as people not only use opioids, but just about any type of psychoactive substance. And this is what creates the devastating effect. We talked about cravings, and I would be somewhat familiar, and I'll talk more about cravings in just a few minutes when we get to safe medications. About withdrawal-induced, drug-induced, and cue-induced, I would understand what those definitions are. The craving types, one is a stress-induced craving, and one is a cue-induced craving. Type 1 is cue-induced, type 2 is stress-induced. Most people have at least a combination of both of those, or at least has been my experience. And the craving is significant in that it lasts longer than a high does, about 3 times longer. And so when a person starts, you know, and that's what we're doing in treatment now, is having them identify craving scores, usually 0 to 5, 5 being the highest I want to use right now, 0 being I have no craving whatsoever. And we kind of give them parameters of how they use that. And we want them to do it because we also teach them the link that it can happen. It's not just an instantaneous thing and it goes away. It is there and it doesn't go away. And it's there for a prolonged period of time. And then we talked about the neurobiology of reward and the pathways and the changes that occur between the reward brain, which is dopamine, the endorphins, dynorphins, and the anti-reward brain, which is glutamate, GABA. And the balance or the imbalance that is created as a result of substance use disorder. And again, this is the level of activity inside of the brain of different classifications that we've discussed. And you can see the lower in the brain that it occurs, the more highly addicting it becomes. Eddie says, I still have occasional cravings for cigarettes and it has been 12 years. Right, Eddie. And of course, nicotine, as you'll see, nicotine listed on this slide is in the nucleus accumbens, and it's connected closely to the VTA. So nicotine is a highly addicting substance, which means it is very difficult to eliminate the great memory and the cues that go along with people with nicotine use disorder. But you have to say, I've got to go do something else, whatever. And we have lots of those that are available. And that's why we have so many folks who are in recovery from alcohol or cocaine or opioids, or whatever, also continue to smoke or dip or chew tobacco products because it still has that addicting process to it, as well as some other behavioral processes too. Food, sex, gambling, and other things behaviorally are tied to all this. Some people just quit one and they continue others, and it still continues problems. We talked about the changing of the highway. I put you this as a matter of just being able to explain this to possibly to your clients or your patients about the brain recording it as a good memory short-term. Dopamine changes, the endorphin changes, the dynorphins change, and then the brain simply replaces the deficient dynorphin system with the drug of choice. And once it's hijacked, that becomes the primary reported relationship of importance in that individual. And that is what we call addiction or a substance use disorder. Once it occurs, it is irreversible and it becomes a chronic disease, not acute disease, a chronic disease. So when we look at the receptor sensitizations, we have circuit 1, it means I really like it, that's dopamine. Circuit 2 is the endorphins. It says not only do I like it, but I want it on a regular basis. And then circuit 3 comes about as a result of the diminishment of the dynorphin system, and it sets up a craving which says, I must have the drug to live. That becomes a compulsive instinctual response, and it's what a substance use disorder is about. The reason that the opioids are so overwhelming, and this is some fairly new reference information that I just share with you, is because if we look at the targets inside of the endogenous opioid system, and this is like when you take a hydrocodone or oxycodone or heroin or something, you will see 6 different areas of the body that are affected, from the GI tract, the blood cells, the integral system or the cellular compartments with the kinetocytes, the muscular system, the peripheral nervous system, and the central nervous system, and multiple parts of that. And so most people don't seem to understand what that's about. But it was interesting when I read this, and I'll show you this. They have come up with a theory which is called the opioid tone theory. And it's kind of interesting that in the brain, when we have normal dynorphins, endorphins, we have that healthy functioning. But when we have a overdose and then we go through a post-withdrawal because of an opioid use disorder, it creates a fibromyalgia-like circumstance for the individual. In other words, there's pain, there's shakes, there's a focus on only how do I get rid of this. It's kind of what they say, the left side of the x-axis corresponds to low opioid tone associated with post-acute withdrawal syndrome and opioid-induced hypoanagesia after opioid withdrawal and with fibromyalgia. And so what happens is this person is in a constant state of pain. And that is on the withdrawal side. And then it's interesting when you go past healthy function and you go on the right side and you get too much opioids, guess what? They say that is kind of like an opioid maintenance, the maintenance of an opioid tone, and it's associated with patients maintaining on opioid drugs. And also people act as though they have autistic-like behaviors. In other words, they have a perceptual alteration of their environment. And when I saw this, and as many individuals I see with opioid use disorder, it started to really, really make sense of how we begin to look at the low opioid tone individual and the high opioid tone individual, and how that would relate to the treatment. How do we take one back to healthy functioning? How do we move one towards healthy functioning? And the reason I share all this with you is because this is one of the main reasons I think the importance of opioid treatment programs and maintenance, if it be with buprenorphine, with naloxone, methadone, naltrexone, would be helping move either side of this axis to the middle. But anyway, I'll just bring that out for your thinking and for your discussion. So with that, which treatment do we choose? And so when we look at the treatment pathways for opioid disorder, and we have like heroin users, we can send them to detox, okay? And then after detox, and this happens to probably about 25% of the population we see currently, then we move them into an abstinence-based post-detox treatment with multiple options, and that can be ASAM. And this is what I want y'all to do with the cases. Do I put them on level 1? Do I put them on level 2? Do I put them on level 3? Or do they have to go to level 4? Or do I put them in level 4 and then I move them to level 3 and then I move them to level 2? Do you understand? That's kind of what all that means. Or we can move them to what we call maintenance or treatment or therapy, which are the medication-assisted treatments. We put them on methadone, we put them on Suboxone, we put them on naltrexone, whatever it might be. And then we may have to detox them from the maintenance treatment, then put them in an abstinence base. depending on the individual. Now, this is all individualized. On the theory, you can do anything you want with the cases, but the thing about it is, this is kind of how you have to do it. So I have to many times have to move one from one and move one down here, then I have to move one over here and move, and so on and so forth it goes. Now, a lot of times you don't have those options because these folks don't have those resources. And that's another detrimental issue, is whether or not they have someone that will pay. And that's what the sad thing about this is, as devastating as this is to the brain. And you're right. You're right. Geraldine, it is a sad thing that I only have one option for a person who probably needs three choices. And I appreciate you saying that, Geraldine, about sadness. I have to tell my students when they come to my clinical site, which is an outpatient 6-week treatment program, private, it's private funded. They can either use insurance or money. There's no free treatment there. So people have resources and have jobs and other things, kind of highly motivated to change if you think. I tell them the one thing I have to deal with them and I have to debrief them every day is how sad that circumstance is, how sad that is. And I said, it's not only sad for you, but it's sad for that individual who's trying to figure out what I'm going to do. And then the families, when we have families coming in on Wednesday and we have to sit down and then we have to train and teach them all that, how sad that is. It is. It makes you wonder, will anybody ever recover? Will anybody ever recover? So if you see people who are in recovery, and I know a lot of you know people in recovery, and some of you may be in recovery yourself, that is a true miracle. It is a true miracle. It is one of the things I tell my patients, do not ever diminish one day clean. Do not ever diminish that, because that is something that a lot of people will never obtain. So it is something wild. But with opioids, we have overdosing is the #1 issue. And again, we have had an estimated by the end of this year, close to 1 million deaths as directly related to opioids or combinations of opioids in those deadly combinations. And of course, an overdose, major issue is respiratory depression, where you have the slow, deep respirations go to 2 to 7 minutes. And they go less than that. Pinpoint pupils, they may not be dilated if brain damage has occurred. That's true, may be dilated. And that's when you see, when they're dead, that's when you'll see that. Or severe brain damage has occurred where the brain stem is maybe the only thing that's surviving. You'll have a low blood pressure and a pulse rate. You'll have a low body temp, cool, clammy skin, and they can be comatose. In other words, they don't respond. In other words, when you do that sternum rub and they don't respond, and you do the slap and you say, hey, can you wait? And they don't respond, they don't grunt or anything, then we got pretty serious. The treatment of that is for the reversal with naloxone. And y'all have the slides for training. A lot of you have been trained in naloxone, I'm sure, in your professional associations. But the thing about it is it's an important thing. If not, please do review and come familiar with naloxone, because you never know when you may have to use a kit or something that's available, and a lot of facilities are now having those kits available. If you're seeing substance abuse and substance use disordered individuals in a outpatient clinic or inpatient clinic, whatever, I'm sure that y'all have naloxone kits available, because you may end up having, as we did, having an overdose in the lobby. And we had to use naloxone in order to resuscitate the individual and call 911 and get them to the hospital as soon as we could. But the thing about it is, it happens. This is a program that I'm very proud of that I helped the Medical Association of Georgia put together. And it's think about it. Another association, medical association in various states, have the same thing. But the thing I have to tell people is the first thing you do if you suspect an overdose is you call 911, because they've got the equipment, they've got the expertise, and they've got the medications that it may take more than one. I've had some people have to take up 4 doses of naloxone in order for them to survive. But then you administer naloxone and then you give the first aid to the overdose. So it's an important thing to be aware, and especially in our current societal situation with the epidemic from opioids. So please use that. multiple types of kits. I won't go into all of this, but we have the nasal adapters, we have nasal sprays, we got the muscle injectables, and then we have audio injectables that are a part of all that. I just wanted to do. Most states now, and this is in the state of Georgia, and also multiple states, usually out of the Department of Public Health, who has a medical director, usually ours is the commissioner, one of the commissioners. You have a standing order that you can provide naloxone to someone without a prescription, because by law, it's a prescription item, but people can come and sign for it and purchase it either through check, cash, or insurance. A lot of insurance companies have now picked it up, and because they know that it is something that will save them from other issues, person going to the hospital and all that type of stuff. So it is something that's important that you know what your procedures are in your particular states. Eddie asked, can it be stored? Yes, safely in vehicles it can. Actually, naloxone is pretty stable. What you don't want to have happen to it is high heat, but it still can tolerate the heat temperatures up to 90 degrees for a sustained period of time. The problem is, y'all, a lot of these naloxone products, and I don't know exactly why, and I've noticed this recently, have shorter expiration dates, shelf life, but just because the expiration said it's expired doesn't mean expiration date on a prescription medication means that that medication has lost about 3% of its potency theoretically. So it doesn't mean you can't take it and can't use it. And if that's the only one you got and it's got an expiration date of July of 2019, I'm probably going to use it. So, but yes, you can store it in cars. We would prefer it in a cool, dry place, but the thing about it is it can be stored and it's usually pretty well tolerated. It's a great question, great question. The second issue with individuals with opioid use disorder, then it's not safe, particularly in high state. No. In the state of Georgia, a car in the shade, maybe, but in direct sunlight, not. Joy said in CT, it's been real difficult for me to get it as a professional working in the field. They want to give me a diagnosis of an opioid disorder, or they won't give it to me. Really? Well, that's an interesting thing. We don't have to do that here. We just have, all they got to do to get naloxone is a driver's license, an indication they want it, they sign for it, they pay for it, they get it. The problem that we've got, by the way, Joy, is distribution of naloxone through the pharmacy distribution. We have some pharmacies that don't carry it because they don't have a lot of people ask for it, so it ties up inventory, so they don't think it's worth it. And of course, I've had a lot of discussion in pharmacy. I don't know how it is in psychology, that some pharmacists just prefer, well, they'd be better off dead, you know. And so I've had to work real hard about that and deal with that issue pretty much on a constant basis. But again, we have that stigma, you know, we have the stigma of having to deal with those individuals. The second issue, there's withdrawal, and mainly what withdrawal is, that's what medication-assisted treatments are about. And that's why I shared the book with you, the new book about what that treatment is all about. It's a good book, and the link is posted in the chat room. And so if y'all want to look at that and look it up, I would suggest you get it. It's free, but you get to know something. We talked about withdrawal, and extreme withdrawal is difficult to manage. 20 days of withdrawal, and this is methadone, but you can look at heroin. Heroin has 10. I've had heroin withdrawal last longer than 20 days in individuals. It depends on how much they use. So, and it's a very uncomfortable withdrawal, as we talked about yesterday, with all of those symptoms. So it is a problem, and that's why MAT is there. It is one, to manage withdrawal. MAT is for managing withdrawal. The predominant medical reason that you go to MAT is to manage withdrawal. But the secondary, and probably more important, is to prevent overdose, because people will overdose as a result of going to street drugs. So that is the two issues that we got to deal with as it relates to that. And again, here's your withdrawal, pain, agitation, dysphoria, dilation of pupils, blood pressure, sweat, urine, diarrhea, etc. If we look at this and we have different types, and the dark blue line, again, is the severity of withdrawal. And as you see this withdrawal, it's extended past 10 days. Then we look at methadone, and methadone, what it does, it's simply, as you see the titration of it, about that 5th day is when you have the lines intersect and you begin to manage that withdrawal to the point that they can feel more comfortable. Now, it doesn't mean that it doesn't reduce severity of the withdrawal immediately. It does. But if you see the withdrawal pretty significantly based on how much, you see that. Now, if you look at buprenorphine, which is the dotted line, you see it has a higher onset and a quicker onset, but then it lowers, and because it's so effective on that receptor, depending on dose, if I was to give a 16 milligram dose, it will cover almost 70, 80% of the receptor. If I give a 24 milligram dose, which I rarely do, it will cover 96% of that receptor. And you begin to see that that person's functionality based on buprenorphine is actually improved quicker than it is with methadone. Methadone is pretty slow onset. It works well and it has lots of good props, but it does have a lot of drawback from the standpoint of onset of activity. And again, the withdrawal is kind of like this picture with all of that, and that's when I give that to you so that you can have that as a part of the indication. If you blow it up and hang it up, people won't talk about what it means, so that's what it looks like. So medication-assisted treatments is simply any treatment for opioid use disorder that includes medication. You can be methadone, buprenorphine, naloxone, naltrexone. It's approved by the FDA for opioid use disorder, detoxification, and also maintenance. We do detoxification, and now we do maintenance as far as buprenorphine is concerned in the facility I'm at, but a lot of it is just basically detoxification, been doing that. It also provides, can be provided in an OTP or an office medication unit, pharmacy. In some states, pharmacists are allowed to do MAT. Physicians can do it. Buprenorphine, a physician's office or healthcare setting. And then you have comprehensive maintenance, medical maintenance, interim maintenance, detox, and medical supervised withdrawal, or types of MAT. And all of those are listed in the book at the multiple levels. You have 7 levels of care in OTP programs that are licensed by the federal government. They are only licensed by the feds. The states will come in and stamp over it, but they are licensed by the feds. And so the thing about it is they're pretty comprehensive in how they look at different patients at different situations. Again, here's the drugs that we mentioned. I won't reiterate those. And the third is the cravings. We're going to manage cravings. And so if I'm going to manage withdrawal with methadone, OTP, I manage cravings with various other medications, if it be withdrawal, cue-induced, or drug-induced. And so methadone and buprenorphine are for withdrawal and to prevent overdose. Naltrexone is for prevention of overdose, but also for cravings. Naloxone is for overdose, but we're looking at it as an anti-craving medication also. And then the comprehensive care that we talked about yesterday, I won't reiterate that because of our time and the things that we have to look at. Now, how many of y'all do pain management? Okay, Geraldine, I do. Anybody else? Heather? Eddie, no. A little? No. No. Some. No. Well, for you that are going to be in the prescribing world, you were going to do pain management to some extent. if it be depression, post-traumatic stress, whatever. So what happened, y'all, and this is just a brief overview. I'm not going into this, but it's a good way. They've updated what we call the CDC guidelines for prescribing opioids for chronic pain. And they also have now got a CDC guideline for prescribing opioids for acute pain. So you have both sides of the equation, and this is the chronic pain piece. And what this was, and basically this is basic pain management. This is basic pain management. All it is in the beginning was patient pain management. So the original side guidelines were primarily for primary care providers in order for them to be able to use appropriately any type of pain medication, including the opioids. And it talks about how do you treat patients who are adults. It now has a portion of there. How do you treat patients who are under 18? What type of settings you need to be involved with. But the thing that it had drawbacks with, it didn't cover active cancer pain. And that's what the oncologist had me to come and talk about to them, because they didn't know how to deal with cancer pain. And there's all kinds of scenarios with that, and palliative care and end of life. So even though they're there, but they've been updated, so there's probably a pretty good idea if you're doing it and you haven't looked at them, and most of you probably have, but the thing about it is they're there. It has to do with the clinical evidence summary, and they have a pretty good idea about what is working at current medical practice versus non-medical practice. And to be honest with you, we're not real sure. There's some things we're not real sure how we're going to manage. The interesting thing that came out of this, they think that the opioid use disorder percentages in primary care vary from 3 to 26%. And they say that it depends on the number of opioid prescriptions that the particular practitioner is prescribing or giving. And the thing about it is, there's been a lot of work, and I look like I'm gonna have to retire from the academic world and go back to the consulting world, mainly because of trying to train these medical boards to understand what needs to happen, when, where, and how in various types of circumstances. And so that's a big deal. They basically, the recommendations were broken down in several types of recommendation. I'm not going to go through all of this. I'm going to give you the information that you can get this if you want to. But you determine when to initiate and continue opioids for chronic pain. Again, how to select which opioid, what dose, what duration, what follow-up, when to discontinue, and how to discontinue. Assessing the risk and addressing the harms is also an important component of this. And so what we do. Now, with all of that said, one of the things that they didn't really talk a lot about, and I will mention, and I threw this out to y'all a while ago in our opening this afternoon or today, was looking screening instruments overview and looking for screening instruments, hidden substance use and abuse, subjective or self-report versus objective, active or latent testing. And really the places that I find is painedu.org, AppalachiaWare.org, are a couple of good websites that I find accessible pain evaluation tools that may be used. You can buy them. There's the SOAP, and there's all kinds. The ones that I see, the subjective is, of course, your interview, which y'all are good at, your CAGE and your trauma test. You've got the government likes the DASC, which there's a DASC-10, and I use a DASC-27. Then you have the reassessment, which is the current opioid misuse measure, which is the CALM. Then more objectively is you have an addiction behaviors list that you can do. I don't know why this thing does it. As was mentioned by some of you this afternoon, you have the screen and opioid assessment for patients in pain, the SOAP, which is the long version. I think it's 24 questions, and they have various short versions. And then the opioid risk tool, which for anyone that's going to be prescribed for any reason an opioid needs to have an evaluation just to see what the risk is. And the problem has been in US medicine is time. Now, when you develop the risk and you have an assessment, then you have some idea based on research What level of care? Level care 1, primary care, no history of substance abuse, limited psychopathology. Level care 2, primary with specialist support, history of 3 years substance use, significant family history. Level 3, specialty pain management, acute substance use, major psychopathology. Patients can move from one group to another, new or uncovered issues or information as discovered in follow-up history. As I'm training my new med students and new pharmacists, pain management is fascinating. It's a fascinating world as you and it's a better evaluated world. And I think it will be something that if we spend more time with this, we will have less people die. The only problem is we tend to, in this culture, we tend to depend on a medication to manage social ills. And then we do that in a lot of more ways from a prescription standpoint than we do from someone out here just taking a drink. But the thing about it is, that's my opinion, so I'll keep it to myself and to you. But the thing about it is, it's one of those things we see. If you want more information, here you go, www.cdc.gov. We are missing the therapy in MAT. The poorly constructed OTPs. Now, let me give you, and I appreciate you bringing that up. It's an important thing, Brendan, and I'll let all of you know this. The state of Georgia is a large state in the East Coast, one of the largest on the East Coast. 2 years ago, had 77 OTPs licensed. And of course, we had, the election and the government, and they said they'd come out with millions of dollars that they were going to provide to states in order to provide enhanced OTP. But the condition was, according to the federal government, which was a smart thing, is that all the ones that they were going to receive funding from the state, and that was coming from the feds, had to pass all the checklist criteria based on federal regulations. Well, when they went and did a spot check, 80% of the programs failed. And so what the then governor of our state did was fire the entire staff of the people who were regulating, because they didn't care about it. They just did the paper and pencil. And so, and I was responsible for going in and training all the new inspectors and also the director, who I've come to really appreciate. They went and evaluated all 77. 46 of them were put on probation. They had a 30-day period to come to standard in operating procedures according to the federal government, where they have all levels of care, including counseling, group therapy, individual therapy, as recommended in the book and in the literature. But guess what? They just were medicating. That's all they were doing, is medicating. As long as people medicate and they don't give the information and they don't get the education, it really doesn't benefit the individual. They closed down 10. They put probation on 20. They closed down another 10. And since that 10, we only have so many slots. New people have come on board with appropriate credentials, and they have replaced the people that would not or did not do what they were told to do. And so guess what? We now have an overall history, which is the first time in Georgia. And that's for us in the mental health world and the substance use. It's amazing that we have now got such better care for these individuals, because when my students go over there, they watch them, evaluate them, they watch them depend and watch the physician make a determination of if they're going to do buprenorphine or that. And then they go to group therapy and they talk about it, and then they have multiple tiers that, and that's what we need. So anyway, with that said, hopefully the same thing can happen in other states, we hope. But anyway, CDC overdose website, there you go. Help Self Tools. That's right down the road from me down in big hot Atlanta. And so hopefully that will do. Patient criteria, pay attention, because y'all are going to be doing cases here. So you want to know about this. So I'm going to try to go through this. All right. I decided to throw this in here just to make clarification. I didn't want y'all to think I'm going to give you something that I did not explain to you. So I'm going to try to give you an explanation in the next 10 to 20 minutes in order to understand. we have clinical managed, we have medical monitored and medical managed services in the criteria. Clinically managed means it's directed by a non-physician addiction specialist, can be a psychologist, social worker, a appropriately credentialed CAC, addiction counselor, usually with a bachelor's or master's level at least. Nurses, those people with primary problems involve emotional, behavioral, cognitive readiness to change, relapse, recovery concern. Intoxication, withdrawal, biomedical concerns are all minimally addressed if they're stressed at all. So clinical managed folks don't do a lot of detox. They do, but they do it very limitedly. Medically monitored means interdisciplinary, you have staff, nurses, counselors, social work, addiction, physicians, and others, more or less on the stabilization, and we have those. Medically managed means they do have daily medical care, but they're not on site all the time. So that does make a difference in when you're making a determination of what you want to see happen to. So we can look at two ways in the relationship of ASAM, the patient placement criteria, second edition revised, which is on the left, and then the addiction severity index, which is another way that people do this. So when we look at ASAM dimension 1, that is usually the medical or detox dimension, and it has to do with acute intoxication or severe withdrawal potential. And so we look at the first dimension. ASAM 2 mainly deals with the biomedical conditions and complications. That's if they have diabetes or high blood pressure or something along that line, kind of the medical status. And ASAM dimension 3 has to do with kind of what y'all are involved with a lot, is the emotional, behavioral, cognitive complication, the psychiatric status. So I want y'all to know that the dimensions, and when you look at the criteria, they will have various types of dimensions based on 1, 2, and 3. Now, I'm not expecting you in your cases to tell me what those dimensions are. I just want you to tell me what level of care this particular patient needs to go to, okay? And what may be some of the management issues or treatment team issues or treatment treatment plan issues you need to look like this person needs to address. We look at dimension 4, which is the readiness to change. Is this person ready to change based on, motivation, ready to change, the system? And what may be cause the readiness of change, and this is an example, would it be because of the marriage, or would it be because of the legal system, or would it be because of the job? Dimension 5 has to do with relapse potential, whether or not they're going to continue to use, and this may be related to both long-term drug or alcohol use, or it may be because they have a significant bipolar disorder or their ADHD or whatever. So that 5th dimension has to do with relapse and what we need to do to address relapse potential in the individual. And then dimension 6 has to do with the recovery environment. What do they have that's in their favor? Do they have a supportive job? Do they have no legal history? Do they have a supported family? Or what is not in their favor, et cetera, et cetera, et cetera. And so that's what the 6th dimension is about. Now, once you look at those dimensions, when you look at the patient placement criteria, then we look at the levels of care. And dimension 1 deals with detox services. And so we look at what levels require detoxification. Not all the levels require detoxification or have capabilities of detoxification. So when we look at the levels, 1D has detoxification, 2D has detoxification, 3D has detoxification. And then if we really want to twist the microscope a little more, in 3.2D has clinically managed detox, and 3.7D has medically monitored detox. You understand what I'm saying? And then level 4D has medically managed detox. So you would pick, if they need detox, or detox is a part of your diagnosis and you're part of your criteria, then they would want to be at least placed in at least one of these levels in order to address that issue. Okay. If we're looking at residential, and residential usually means somebody has relapsed has the inability to stay sober for any length of time, and require closer supervision, these are the levels of care. Level 3-1, a level 3-3, a level 3-5, a level 3-7, and level 4. These are the ones that you can do. All right, I see a question. Hang on, I'm coming. If I can get it over here. I can't move. Oh, okay. Can you give me an example of medically monitored versus medically managed? Medically monitored would be where you would have the physician come in 2 days a week, might see patients, do physicals, might do med checks. Medically managed would be where you would have a physician there almost all the time, and they're closely supervised. Medically monitored is where they're there 24/7, whereas medically managed, they're not. And it depends on the level of hours. Most residential facilities, unless they're very large, usually are what we call medically monitored. They're not medically managed unless they have a crisis stabilization unit. That's what we mean. Yeah. And that's why I'm going over this, because the terminology can be somewhat confusing, but it also would help when y'all look at your cases. And then that's what I want y'all to have, because when you see somebody, and y'all going to see somebody and you do this evaluation, you'll want to know, well, what am I going to, and then you've got to decide based on what you see, what can they afford? And 2, what's available in your area. I am the only outpatient facility in an area of 70 square miles. There is no inpatient. If I have to have stabilization, crisis intervention, neither hospital here does that. We have to send them to Greenville, South Carolina, Atlanta, GA, or Macon, GA. If I need residential, based on the level of care, and most of mine require either medium, like here, clinically managed medium intensity, or usually clinically managed high intensity. I don't have either one of those here. I have a lot of them are clinically managed low intensity. In other words, they've got a halfway house. They have a group every night at 6 o'clock, and then they make them go to a meeting, and then they go to work every day. But there's no one there 24/7 to manage them. So you have to make a decision about what that's about. So when we look at the differences between inpatient, residential, and outpatient with supported living, inpatient's basically 24-hour, and this is only for people who are in imminent danger, either from relapsing and overdosing, or suicide, or whatever it may be. They're in imminent danger. That's an inpatient requirement. That's level 4. Residential provides 24-hour structure, or some do. Primary medical services are not usually necessary. In other words, these folks are ambulatory. They're in good physical health. They're able to come to group or go to work, both. And the thing about it is, it can be used for patients in imminent danger, and the imminent danger would be not from a psychiatric standpoint, but from a relapse standpoint. An outpatient with supportive living means it provides structure and support. Primary medical services are not necessary, but the patients are not in imminent danger. The ones that come to our facility are not in imminent danger. They're able to maintain sobriety. They're not suicidal. They can become suicidal, and relapse does occur. If that's the case, sometimes we have to move them to a different level of care. But the thing about it, the majority of them come in and they're motivated. They want to do it. That's why I bring students over there, because I have students see people get better versus the continual resistance that I see in a lot of programs where it's in the mental health center over here. It's a horrible place to try to train students to learn how about recovery, because not a lot of people do it because they just want detox, and they're very resistant, and they create all these problems. A long story short, it's not something that I want them to see. I want them to see people do get better and can get better. So All right, I'm gonna stop for my 5 minutes. I'm gonna get me a new bottle of water, and we'll come right back and we'll continue this overview. Okay? All right, thank you. I am going to do some cases. I am. They may not be text, but they will be answers to the questions. Yeah. I'm going to show, I have some PowerPoints that I'll show you kind of an idea that I've put together for medical residents. So we'll have some answers. And then we'll discuss. I really want y'all to decide what kind of treatment. I mean, I know what kind of treatment, but I want y'all to tell me what type of treatment you'd give and why. That's what the whole purpose of this is not only to look at and be familiar with the criteria of substance use disorders, but give me the level of care. And then what we're trying to explain here, the experiential component, which is hard to do because it has too many facets to it, but is to look at all of this. That's why I'm going over this now, is to be able to pinpoint what we might do and the reason for it. Because you might have somebody come in the office tomorrow and that's what you have to do. And you say, well, what does this dimension mean and what this? So yeah, we'll do that. But a lot of this is I'm going to put what I have partial, the answer, and then y'all going to give me the rest of the answer. And then we'll discuss it and then we'll come up with an answer. But, and I think I'm going to try to cover cases 6 through 10, which are the more complicated cases. first 5 or not, I'm gonna let y'all do that, but I'll cover enough of them so that y'all have a reasonable way to answer those cases without it being overwhelming. Okay. All right. Very good. You're welcome. So I think I got everybody back. So here's the cases we talk about. Level 1, level 0.5 is early interventions, kind of like DUI school, psycho-ed. And some of y'all may have this in your facility or in your office. I know when I was in private counseling practice, I had 2 of these. One was for federal probation. One was for state probation. I never set up the DUI because the DUI programs here in Georgia are just overly supervised by the state. But I did the early intervention. Outpatient, we talked about levels of outpatient, usually less than 9 hours. That's usually less than 9 hours of treatment per week. The intensive levels of outpatients are anywhere from 12 to 20 hours. Partial hospitalization is over 20 hours a week, but it's on an outpatient basis. They go back and forth. Residential is 24/7, depending on the level of management based on what we talk. And then level 4 is medically managed. And that's crisis stabilization. That's 24/7. And so that's one of the things. All right. Level half is not a level of care, but it's combination psycho-ed and assessment. The assessment indicates the need for treatment. The individual may receive treatment at the conclusion of the 0.5 service currently. This is what a lot of the DUI individuals do. They have a clinical assessment that's required. They have to go to so many hours, usually a weekend, to the DUI training. And based on the assessment and the training, then they may be referred to a more extensive evaluation, especially if they've had, I know in the state of Georgia, if you had 2 DUIs within 5 years, you're automatically referred to a clinical assessment team. And you still have to go to the psycho-ed, but from that, they can recommend up to a year of treatment at various levels. And so, but level 5, 0.5 is not usually a level of care. It is based on assessment. Outpatient, as I said earlier, is less than 9 contact hours a week. Level 2 intensive outpatient is 9 or more contact hours a week in a structured program, and 6 hours for adolescents. Level 2-5 is 20 or more hours a week in a structured program. So there's specific agendas and what you got to do. The 4 Ps is patient, participation, assessment, problems, priorities, plan, and progress. And you try to match severity of level of functioning with those 4 Ps. And so we have that. And that's your references. And there you go. All right. Y'all got that? Was that helpful? Did it help any? Y'all probably are asleep by now, so it's okay. All right, one more set, and I'm going to get through this. We're going to talk about safe medications, something that a lot of people don't know about. And this is what I give to families, and I give to patients. We have a medication group, usually once a week with them there. And of course, my rotation schedule has changed a little bit. So, but the thing about it is, I'm going to go through. So this is safe use of medication to recovery. I wrote, along with Dr. Talbot, back in 1986, the first safe use of medication pamphlet. And I posted for you a very good medication, a safe medication pamphlet and guide in the resources in Moodle. So if you're interested in this, there's one there in Moodle. And if you want more information, let me know. And there's others that are available. But anyway, this is a combination of these. So we talk about the reasons for medication safety. This is kind of a medication safety discussion. So why do we want to have this discussion? Well, who is at risk? And what we're trying to prevent is the use of medications in a recovering person that may create a relapse. And so what that who's at risk is a person who may have struggled with a substance use disorder, have a high risk of becoming addicted to any medication. over the counter or prescription. It's important to know the best medication to take in order to avoid relapse. And so some of the medications can cause excitement or depression in the brain, which can lead to negative or craving pathways in an addicted brain. This could be the cause of the development of a new addiction, or the presentation is designed to teach you the appropriate use of medications in recovery. So that's kind of what we set them up for, and my students teach them this, and as we try to give them that information. So here we go. There are rules that people need to follow when it comes to the use of medication, and they're also in recovery. One is you don't self-medicate. The second one is you don't change your dosage or frequency of medication without a consultation from either your treatment team or hopefully from the treatment team, your physician or pharmacist. You don't stop taking medication without consultation without that same treatment team, physician or pharmacist. You also need to be aware that there are over-the-counter medications that can cause relapse. You need to follow the one physician, one pharmacist rule so that the protocol can be, and a lot of this has to do with the prescription drug monitoring programs that are in states. You need to learn to ask about your medications and not what you got to do. And in the course here in this particular guide, because that's where I'm at, you need to follow the Athens Area Commencement Center medication guide, which we developed and we update about every 6 months. And so we have that as a part of the discussion, and it's in their hand along with the families. And so we begin to go through it. So the first thing we look at is over-the-counter meds in recovery. And then the rules for safe medication is, and especially with these, you avoid any medications that contain alcohol, and they can be cough syrups or NyQuil or vitamin supplements. You want to avoid medications that contain stimulants, and they can be appetite suppressants, Excedrin, caffeine, pseudoephedrine, phenylephrine, ephedrine, epinephrine, some asthma meds. You want to avoid medication that contain any type of narcotic that may be used for pain relief or as an antidiarrheal. And we have some paregoric based preparations that you can sign and exempt narcotics. And so, yeah, hand sanitizer, that's right, DXM, all of those, yeah. Avoid any medication that contain depressants for anxiety or sedative hypnotics. Benadryl is a big one. Robitussin, Dramamine, Unisom, any of these generic drugs that are listed, you want to avoid those. Not saying you can't use them, but there are only certain circumstances that they would be the best to use. I recommend Benadryl for emergency situations. If you have an allergic reaction, please take Benadryl. But otherwise, don't take it for sedation. Don't take it for any type of reason, because it is a sedative antihistaminic preparation. So we don't want to do that. So, but we begin, and people begin to add, why not Benadryl, blah, 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 blah. And so you have a good interaction with that. The first step in practicing medication safety, and I tell any patient this, I don't care what you do, learning, and I don't care if you're just a new diabetic or a new anticoagulant patient, or a new chemo patient, whatever it may be, a new recovering patient, you need to learn to correctly read a drug label on the packages that you're fixing to purchase. So I have to teach them what the drug label is and how to read it. So we look at active ingredients, which is important. You look at inactive ingredients, which is really more important. You look at the appropriate dosing on the package. And then the biggest thing you look at is the maximum daily dose. The worst case scenario is ibuprofen. Ibuprofen. And we'll talk about ibuprofen in the normal way, but there's a maximum dosage that we have for ibuprofen and naproxen, aspirin, and other things. So when we look at a label like this is why a lot of people don't read them. You can't read them. And what I will tell people is you can't read them for a purpose, because the manufacturers don't like having to put these on here. So they're going to put it on there by law, but in a way that people do not read them. So old people, unless they get glasses, young people, and most people, and look at all the stuff in here. But look at it. Here's one for ibuprofen, non-steroidal anti-inflammatory drug. It can be used for all kinds of things listed here. But here's the warnings. And a lot of people don't know is it can cause severe allergic reaction, about 17% of the population who takes it. And they can include hives, facial swelling, and create a wheezing. If you have asthma, can worsen that asthma attack, can create cardiovascular shock, skin reddening, rash, blisters. And if you have that, and seek help right away. Stomach bleeding. Most people don't know that if you take more than you're supposed to, you can create ulcerations in the stomach lining. Chances are the people who are 60 years over, history of stomach ulcers or bleeding, taking any kind of anticoagulant, you understand. If you read all of this, there's a lot of information here. And so we go through that with them and we talk to them about it. And, but a lot of people think, well, it's an over-the-counter, it's nothing to it. They don't know that it's also a medication that can have some very serious consequences and some very serious adverse drug effects in a percentage of the population. But anyway, we show them that. And then we want to point out, this is what, if you're going to have to read something, this is where I want you to read. This is exactly where I want you to read. And the thing that we're going to do here is we're going to look at active ingredient. We said that. Amount of therapeutic medicine tablets, 200 milligrams. Other ingredients, check for alcohol. Is there any alcohol in the inactive ingredients? We'll find some of those in a minute. What are the uses? We talked about that. And what does it treat? And so we began to show them that. We have them handle packages that are in the group. And so they begin to look at it. And then we look at directions. And then, I don't know what's wrong with my watch. I'm yelling too loud, I guess. We look at the age, we look at the amount, we look at the consequences, and how many can you take in one day? Look, you do not exceed 6 tablets in 24 hours. When I look at ibuprofen, there's a lot of people, they'll take 4 of these at one time. And you can't take more than 6 in 24 hours, recommended. But anyway, so we start looking and they start blah, 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 blah. Then we organize it into a green light. So there are class A drugs, which are safe to take at any time. There are class B drugs that you have to take with some precautions and supervision. And there's class C drugs that are not safe and they would require, if you had to take them, extreme supervision. So we begin to show them that. Class A's are generally safe. They're not bad when it comes to addiction recovery. Class A's are generally safe for use of recovering individuals. All medications, even over-the-counter medication, can lead to undesired side effects if overused. Remember, do not self-medicate without approval of treatment team. So even if it's an aspirin, an ibuprofen, we want them to learn to ask for that question. We want them to learn to ask permission. Then we show them the low risk, and this includes antihistamines, and I won't go into all the GI. And we show them the alternatives. We use Claritin and Zyrtec, not Claritin D and not Zyrtec D. And there's no Ds. We don't take Ds, and we try to give them those little nuances so they'll remember. Antibiotics, cardiovascular meds, antidepressants, psychotropics, those types of drugs, we tell them take only as directed, and take them, for instance, an antibiotic, you take it till it's completely gone, or as on the label. Class B, they're useful in treatment. Potential abuse of side effects may be used with treatment team or physician's approval, can become habit forming. So we want to do that. Class C, you want to avoid at all costs if it's possible. If you're unsure if a drug falls in this class, consult treatment team. Again, we're asking for them for consultation. And will all of them do it? No. But 70% will do it because they didn't know a lot of this. And some of them say, well, that's where I started using this when I was 14 or 15. You know, it's kind of an interesting thing. And these are things that you would avoid, and these are things that we would probably have to give some very close supervision if you had to take something like this. And we do have some people, a very small percentage of people, who have to take Adderall. We have some people take Ritalin. We have some people that have to take various Fiorset for migraine headaches and those types of things. So there are reasons. So how do you treat general ailments safely with over-the-counter meds, which is a big question for a lot of people. And here's the list for pain. Here's the ones that need to be monitored for pain. A lot of muscle relaxants are listed. And here are the ones that are listed that you've got to be aware that are not safe to use. And most people know that because a lot of them end up coming in with addictions to one of those listed on that list. So you have that. Maximum doses, we talk about Tylenol no more than 3 grams in 24 hours. And this is FDA regs. Ibuprofen, 1,200 milligrams in 24 hours. Naproxen, which a lot of people don't know, it's a 220 milligram tablet. You don't need to take more than 3 of those in 24 hours. Aspirin, no more than, and they've just reduced that from 4 grams to 3 grams, unless there's a cardiovascular reason for you to take that. And that's why they've moved from a 325 milligram, which is usually something they give people when they have bypass surgery, but it's usually for about 2 months, and then they knock it down to an 81 milligram if the anticoagulant component is taken care of. Seasonal allergies, again, we look at this. Steroid nasal sprays are very helpful in that classification. They're kind of remarkable, actually. And these are the things that you don't take. What's wrong with D and PE? D stands for pseudoephedrine. Usually when you see a D attached to an antihistamine, it is for pseudoephedrine. PE stands for phenylephrine. I told you the stimulant effect, phenylephrine and pseudoephedrine a while ago, and that's one of the reasons that we want to leave it off the list at all possible. Cough and cold, Mucinex, guaifenesin, and of course, if you don't have hypertension, you can use saline. You can also use neti pots and other things that are available, but you don't want to use dextromorphan. You want to avoid Benadryl, and you don't want to use anything that has DM in it, which stands for dextromorphan. So you also want to look carefully with the same brand, different products. For instance, this is a mouthwash, and we want to know, and they look very similar, and you have some that are alcohol based and you have some that are water based, and so we want to determine which one is safe. And so when we look at them, we find in the inactive ingredients alcohol, and in the percentage of alcohol in a lot of alcohol-based mouthwashes runs between 2 to 3%. It's not a high percentage, but it's higher than what you need, especially if they don't need to be surrounding themselves with alcohol. So you have to teach them how to look, even though the packages look very similar. Then we got any incidental exposure to alcohol. You've got to be careful with high amounts of vanilla in certain preparations. And again, you've got Tylenol that's got alcohol and antihistamine. Certain soy sauces have high amounts of alcohol, Listerine, alcohol-based, and then hand sanitizer, which I think Joy mentioned a minute ago. But the thing about it is, these are reasons that they can create risk. Some people are on antabuse for whatever reason. I tell them, and people do agree to antabuse, they can have a skin reaction with hand sanitizer, or they can have a lip reaction, or whatever they got to do as a result. And then I ask them, is this safe? So here's a question for y'all. This is not, but we could consider the question: is Unisom safe to take? Based on what we just said, is Unisom safe to take? Great. No, because it's diphenylhydramine, which are most of the preparations. But we ask them that question. Some of them don't know because they've been taking Unisom for 10 years. You understand what I'm saying? They think it's, well, I didn't have anything to do with my methamphetamine use, but yes, it did. So you have this, you list that right there. Then you got melatonin. Is it safe to take? Yep. We've talked about melatonin. It's pure, it's a low dose melatonin. It's safe to take. Here's Benadryl, children's. It's a children's. Is it safe to take? The answer to that is what you said is no. It's because it's got, again, diphenylhydramine. So we have the packages out there, and we have also phenylephrine. It's also included in it, you see. and you use instead of plain Allegra, which is a better product and in fact is a better technology. And so we tell them that. Now, NyQuil cough, is it safe to take? This would be, we don't make them too hard, but we want to make them be aware. No, 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 no. That's correct. That's correct. And it's because we have dextromorphan and also have alcohol. So we have more than one product that could create some problems. We don't take combination products. I also tell them that they don't take combination products. You take single entity products. And that way you'll keep yourself out of trouble. So that means they got to really look for some of this. You would use Hall's Call drops or something along that line. And then when we look at the thing about it is we want to make sure that they don't look at alcohol in any form, sedative hypnotics, opioids, Adderall, marijuana in any form, even though now even medicinal. See, I've had to add that even because they go, is this now legal? And the answer to that is no, we don't. So how do I tell my pharmacist and physician? How do I tell my psychologist that I'm in recovery? Now, this is a big deal. I tell them, you don't go in there and say, I'm an addict or an alcoholic, or I'm a recovering addict or alcoholic. You don't tell the office staff that. You simply list alcohol, opiates, stimulants, sleep aids, allergies on the intake form with a note, please ask for more information. This will alert the provider that this is a serious issue when prescribing, filling medication for you. By following one doctor, one pharmacist rule, you should only have to explain this a handful of times. Don't worry. A good healthcare provider will not judge you. They'll want to help you. And so that's what we run into by helping them understand it. You need to tell them, but you don't need to go tell the staff because the staff looks at you and they start doing that, you know, here's a drug seeker, blah, blah, blah. And they don't need that. They just need somebody to take care of them, but only the people who take care of them need to know. I don't want them to have a big A on their forehead when they walk into a doctor's office. And I tell them that. So it's an important thing. Energy drinks. Okay, here's a little talk I give them on energy drinks. And this is pretty interesting. When we look at 5-hour energy, for instance, and we look at a lot of things that people don't really pay attention to, it being an energy drink, what are they going to look for? They're going to look for caffeine. They're going to look for the thing that, you know, gets them off the ground. Well, what we'll find in 5-hour energy is what we call an energy blend. And that energy blend has 1,870 milligrams of all types of herbal, including caffeine, and synthetic stimulants. Also, it has high amounts of sweetener, and some have sugar. Some have artificial sweeteners, but the thing about it is it's got 1,870 milligrams. So that's not what we want to do. When we look at Monster and we compare an older Monster, for instance, it's got 2,500 milligrams of energy blend. And it's got all of these herbal products that are pretty remarkable when you start seeing what they do. Taurine and caffeine. Now, energy drinks and recovery. Caffeine is a stimulant. Caffeine has an addictive nature, and companies add to their drinks to keep you buying them. It's not that you can't have caffeine, you just got to have a moderate amount of caffeine. It becomes a replacement vehicle for addiction, potential cause of heart damage. And so we talk about it, and they look at Red Bull. My mama drinks 4 Red Bull a day and blah, 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 blah. I mean, we get into all kinds of, this full throttle, they got a full throttle, 32-inch full throttle that has almost 5,000 milligrams of these energy components in them. So it's one of those things. Joy said, I forgot what's in it, but my folks will pop positive on a UA when they drank Bang energy drinks. Well, there's certain precursors of amphetamine in Bang. That's why they call it Bang. And so on a screen, they will show positive. Usually on confirmations, they won't. So that's the other issue about that. But a lot of people just do screens. Now, interesting comparison here. And I always have to move all this stuff. Energy drinks are stimulate pleasure center, similar to alcohol and tobacco. So we compare a Coca-Cola, 12-ounce Coca-Cola. If we compare an 8-ounce Bull to the amount of caffeine in a regular Coke, it contains the same as 3 Coca-Colas, Red Bull, 8 ounce. Full Throttle, 16 ounce, contain the same amount of caffeine as in 5 12-ounce Coca-Colas. Monster has 5 16 ounce and 5 Coca-Colas. Rockstar has 16, has 5. Wired 340 has 4, 8, same as 11. 16 ounce now, 16 ounce, same as 11 regular size Cokes. Yeah, Wired's the one you want. You got that? That's what I need right now. I'm telling you, I'm failing fast. But that is something that a lot of people don't know. They don't realize it's in that much. So we give them that. So here's a health risk. And so what happens, y'all? Guess what? We have a prolonged QT interval, which describes a segment of the heart's rhythm on an electrocardiogram that causes serious irregular heartbeats or sudden death. And so I show them the QT interval, and I pointed out to them with this QT interval, when this interval here widens and this interval here widens and the overall interval widens, the heart gets out of sync. The longer and further it widens, then guess what? The more risk you have for creating arrhythmia or irregular heartbeat. And it depends if it's on the atrium side or if it's on the ventricle side. And the thing about it is, depending on history and other things, guess what? It can create a problem. We're doing it. Joy said, geez, I have people drink 4 or 5 Monster Rockstar. Yeah, I wonder why. Joy, I wonder why. We had to terminate all that. We had to end all that. And they complain about insomnia. And they think it's out of something else, but it's not. It has to do with, again, they're going to hang on to something that they're not told they can't have. Whatever remember, addiction means being off the natural. Means being off the natural. The old timers would talk about being off the natural, or people who shot heroin and couldn't get heroin. They shoot Epsom salts so they could just be off the natural. And that's the same way people smoke, drink energy drinks, do all kinds of things in order not to be on the natural. Smoking. So I'm also on smoking. Oh, it hurts their feelings about smoking. But what I try to tell them is we do have a program in place that we have multiple options that we can provide for them if they choose to want to stop. And we'd like to see them stop within the first year. And this is usually, and we've had about a 80% change in the aftercare group of smoking to non-smoking as a result of using multiple approaches, but they got the idea from this type of approach. And so you can you got the nicotine replacement therapies, you got the transdermal patch therapies, and I try to explain what these are and why there's 1, 2, and 3. We talk about the transdermal patch and how to leave it on and not to do it more than 24 hours. And so it's one of those things. But yeah, well, I hear you, Joy. Vaping, absolutely. That's what we had, the vaping piece. I've added vaping to this. This is not the newest, but I've added vaping to to the program as of 4 weeks ago. But you've already seen the vaping. Here's the reminder. I give them the reminder about what the label needs to be and how they need to read it. And then remember to avoid Ds, PEs, DMs, sedatives over the counter such as Benadryl, etc. And what should you do if you're not sure about safety in a medication? What should you do? Well, you ask your treatment team. You ask the people who you're paying to get you better. And so that's what we do. And there's the sights and there's the sounds. All right. Yay. Y'all all say yay. We're done with the PowerPoints. All right. Let me see if I can make this work now. I'm hoping I can make this work. 10, 9, 8, 7, 6. Let me see if I don't know if I can make this work. I don't know. I've never done this before, so it's going to be interesting to see if I can make this work. All right. Can y'all see that? Hmm. It's small, isn't it? Not really. Hang on. Well, wait on a minute. I thought I had it done. Okay. Hang on. Wait a minute. That's really small now, isn't it? All right. Let me see something here. I can see that bad boy, can't you? Huh? You got it? All right. Hang on. I may take a pause here for a minute. I'm trying to work something out so I can all right, that's the answer. There we go. Thanks. All right. So let's look at it. Looks like everybody, we start up here at the top and we will see everyone's got severe. Okay. You always opioid use disorder, severe, anxiolytic use disorder, severe, in remission, cannabis use disorder, moderate would benefit from IOP or PHP. Okay, excellent. Opioid use disorder, Rebecca, severe, F1 1120. Brady, opioid use disorder, severe, severe. Rebecca says a level 3-7. Okay. And then we got opioid use disorder from Robert, severe, cannabis use disorder, moderate from Heather. Lewis got opioid use disorder, severe, Danielle, cannabis moderate 3.7. Wow. Rebecca said, I don't agree with his judgment is sound and rational, genetic predisposition. He definitely is a type 2. So you may be correct about that, Rebecca. Maribel, opioid use disorder, severe. Brady said, assuming he completes detox at 2.5, assuming he completes detox, and Nabji said he's opioid severe 3.0. Rebecca said that he can go from a 7 to a 3.5. Daniel said local for treatment 3.1. Okay, severe. Angela 11, 3.5 to 3.7. Jason, opioid use severe, treatment level 2, partial hospitalization that include physical monitoring of medication. Janelle says opioid use disorder, PHP with physician. Very good. All right, let's see what he's got here. All right, he's got opioid use disorder, which is pretty clear. He said, and then typically what I do, and this is what I want y'all to do, and that's what I'm trying to show you. If we look at the case and we go back through the case and we have the 11 criteria, as it says down here, BH displays all 11 of these criteria. So what I like when I do diagnosis and assessment is to tell the individual the specific diagnosis they meet. And y'all got that. I didn't tell you to do that, but I'm just saying that for your reports. That's what I want to see, so that you will begin to separate out 1, 2, 3, 4, 5. And this, In this case, it's pretty clear because he's had multiple treatments. He's got multiple drugs of choice, and he's going to have requirement of certain other things. The presence of 6 or more symptoms indicate that the patient's opioid use disorder, and I'll make this bigger so y'all can see it, and I appreciate y'all telling me about the slide. I forgot about the slide on the side. Is classified as severe according to the International Statistic of Classification of Disease, or the ICD-10. Criteria 1 through 4 indicates impaired control, 5-7 indicates social impairment, and treatment criteria 8 and 9 is risky use, and criteria 10 through 11 indicates pharmacological impairment such as withdrawal and tolerance. And so he meets all 11, so he is an opioid use disorder severe, which I think is a good thing. But then this is his 3rd admission, and that's what I like about what y'all have decided. He is in a 2-5. This is a 2-5. This is the type of program that he's in, is a 2-5. So what is a 2-5 going to give him that will be an advantage? What will a 2-5 give him that will be an advantage for him to try to recover from his opioid use disorder? What is the advantage of a 2-5? And he said increased clinical contact. Yeah, he's got at least 20 hours a day. Okay, that's one. What's he doing in his life? Support structure, medical detox, right? But what's he doing in his life? What's he trying to do? School. He's failed school. He's dropped out of school, but he's back in school, and he's got grandparents that are going to pay for school. So one of the things that an outpatient facility, especially an intensive outpatient, will give him, I personally recommended a 3-5 because of his history. He has a genetic disposition, and that means when he's a type 2, y'all, that's a male to male, and it comes from grandfather, both sides of his family. The malignancy of the disease is very overwhelming. And that's why he substitutes one, if you notice his history, he substitutes one drug for another drug, for another drug, for another drug. And this is a 6-week program. I told the treatment team in the very beginning, as best as he's motivated, and on the surface, he, as y'all saw, has a little withdrawal, but he was motivated, but it wasn't enough. It wasn't going to be enough for him to get what he needed to get. And as you look at it, and as we go down, and you didn't get to see all this, the management components, and this is the other part that y'all can put into your report. What we got to do from a management standpoint, if you look at this, is you've got to manage the withdrawal from the opiate. You've got to look at the resistance to recovery due to a lack of disease understanding. And that's a very global statement, but when you look at it from the standpoint of where he comes from, multiple relapses, genetic predisposition, and for him to understand, see, most type 2 males that and I've treated hundreds of them, they don't understand the word powerlessness. And this kid, he's young, and he's had some consequences. He's failed school a couple of times, and he got his hand slapped, but there's not been anything. So unless we put him in a long-term program to where he can understand what that means, and there's consequences for certain things, the odds are that he may not survive. And I'll tell you the end result of that in a minute. They educate on cross addiction. Do y'all understand the concept of cross addiction? Manage 6 to 8 clients, just like BH. They cannot manage our IOP. They need residential first. Do you send them to residential, or do they have to fail outpatient first, Danielle? Okay. So long-term residential will be what would be indicated, and this would be because of the increased need for structure. And the biggest thing, y'all, and this is the biggest thing I see with this particular young person, is the ability to establish sober friendships and activities. And he has not. I agree, Rebecca. We kept the kid 8 weeks. And he was very compliant. I mean, and he's a young kid, great looking kid. I mean, had a lot of things going on, a really sharp kid, smart kid. And he really had no particular other significant history, either from familiar ways or psychiatric or medical, outside of the genetics. And he was dying. He wants to go to med school. And of course, we had a med school there at UGA. And of course, dad was a doc, mom's a doc, and they were well connected. And so he pretty much was guaranteed a slot at the appropriate time if necessary. But because when he really applied himself, but his grade point average below 2, and you're not going to get med school with a grade point average below 2. So he was going to have to make up all this. So he's going to have to spend 3 years in school just to get the GPA up so that he could be eligible. You know what I'm saying? And I'm in Athens, Georgia, which is one of the greatest party schools in the South. And he wanted to go back to work doing lawn service. And, you know, he had all these things, but none of those things worked because he had no sober friends, none. And I told him and his family, I said, absolutely not. I said, the worst thing that we could do is let you go and do what you just said, because I don't think you have a ghost chance making it, because there's no sobriety inside of your circle of anyone. But, you know, again, I think Rebecca said, you know, the family, the dad especially, was the greatest enabler, and he said no. And so he let him go. And within 6 weeks, he ended up with a DUI, hit and killed a kid. He's now in Jackson Prison. That's what happened. And I don't know that there's any chance of him, you know, doing anything else. So it's a very sad. But just to go further with the case, and that's one of the reasons I have actually in these 10 cases, there are five cases very successful and 5 cases that are not successful, by the way. But the thing about it is, as we go down here and you look at this, you know, overcoming, he lied about Suboxone. He was taking Suboxone on multiple levels. Joyce said, we do a lot of family therapy in a program for this reason. It's not just the person getting sober, it's the entire system that has to go. You're right, it's right. But it's amazing, and my mentor told me, Doug Talbot told me, that the family is a year behind the individual coming into treatment. They're a year behind. And he gave me that rule in order for me to be patient, both with the patient and also with their family. But the family just was not, you know, they were all fired up about this is going to be, you know, his dad was one of these, we're just going to get past this and you're going to go on and have a successful life. And unfortunately, that did not happen. But what you're doing and what you're saying, part of what y'all are talking about, and that's why I'm showing you this, that we did all of these screens. He had a score on his Beck depression scale of 11. And then as we did put him on Revia, we did everything we possibly could at this level, but even with that, he couldn't survive more than 30 days when he left because he had no sober friends. He had nothing. And that's what all this is about exactly in this case, what had to happen. And of course, this is where we showed you the detox. And the thing about it is it's one of those things that these are actually what he did as far as treatment. And this is his detox and his schedule and what we do with the protocol and which levels we had the progression with first step, second step, or third step. And then the HUDAS 2.0 is what we do when they come in to see if they're applicable for this type of setting. And so he was moderate. Most of these he could do. And so they determined he was ready. He could come to outpatient, but it wasn't because of his physical component. It was because of the emotional component. Okay. All right. So y'all did good. Y'all did good. It is one of those things. I think there are problems with 12 steps, but one of the best things they offer is a sober community resources support and show people with a life without substance. The thing that we have that's an advantage, Joy, and I say this to everyone, with this age individual, this is the most difficult age to treat, generally speaking, even though we have very good outcomes if you can get them to drink the water. But one of the best things we have in Athens is we have a whole young person's community that does that. And they'll come and they'll sit and they'll talk to them. They'll come and get them to go to meetings. And they're very good with them. They're very good. I mean, it's not just they're pumping AA or NA or whatever, but they're very good. They're teaching them, this is what I do and how I do it. And that has been very helpful. In this particular case, though, it's because the biological component of this compulsive brain that this young man didn't fully understand. Yes, we have a CRC. Yeah, we do. And there are a lot of support networks that are out there, but this is one of the cases. Okay. All right. Y'all ready for another one? Okay. Let's do away with this one. Yeah, I want to save it. That's the only size I got. All right. So let's see what else I got down here. All right, let's see if this is any different. Case 7. All right, let's do a couple more. And let's see if we can get this bigger. All right, here's a female. Yay. Y'all ready to rock? Hope this is helpful to y'all. I hope it's one of the things that we can get the chat going. All right, there we go. Let me take that out. Let's see. They are hard to keep going, though. Our smart recovery is here going with, is going to no more group sessions. Yeah, it is very hard, Eddie, to keep young people programs together. There are online programs that are often that can be used too. All right, here we go. This is a case of marijuana. Marijuana. We got some marijuana. Early recovery marijuana use in outpatient group setting. AP is a 26-year-old Caucasian female. She's currently unemployed. She recently divorced husband, a year custody of their 8-month-old child and 2 other children, 3 and 7, from a separate father. So we have the mode. She referred herself to the facility. The brief history is she entered treatment requesting help with cannabis addiction and withdrawal. She reports smoking approximately a 1/4 ounce marijuana a day, cited having to be high to do anything as a primary cause of requesting treatment. Patient also reports using methamphetamine every 1 to 2 weeks so that she can get something done due to slow motivation induced by cannabis abuse. She also reports of regular use of cocaine approximately 4 years ago with duration of roughly 6 months. Her present history of present illness, AP reports of having a shy personality, describing it as social anxiety, did not make friends easily, and cites social smoking at 14 years old as first experience with cannabis. Through social smoking, she created friendship, pushed her into increased using, and eventually belittled her desire to quit. The overall induction to drugs and drug use was through her now former husband and father of her oldest 2 children, whose sister sold both cannabis and methamphetamine. AP cites the ex-husband's increasing use of hard drugs like heroin as a reason for their separation, 2010, and eventual divorce. The patient reports that the separation from her former husband spurred an increase in her drug use, especially use in methamphetamine, which evolved to daily use from intermittent and use from intermittent to sporadic. Throughout her history of use, AP was able to maintain a job as caregiver for the home health service. After meeting her now boyfriend in 2015, AP stated that she returned to what is considered light marijuana use and methamphetamine. However, her pattern once again increased dramatically only a few months later upon losing the only patient she was assigned through work. This time of money being real tight precipitated increased use that ultimately was rebuked by her boyfriend, who she reports has never been accepting of her drug use. I wonder why. AP was then told by boyfriend that if she didn't quit, he'd be gone. And this, along with the recognition that she had to be high to do anything, were the primary factors contributing to her presentation to the treatment facility. Upon presentation to the treatment facility, AP experienced medium-high depression, medium-high cravings, medium-high physical withdrawal, such as tremors. She also reported high anxiety and irritability. She reported no home meds and was started on gabapentin 100 milligrams TID, Buspar 15 milligrams TID, clonidine 0.1 milligrams at bedtime, and Zofran 4 milligrams every 6 hours for nausea. Neurovegetative signs is currently insomnia, a symptom that she denies was present prior to her drug use. Patient's energy levels reported being medium high. She reports no diminishment in libido, no difficulty concentrating, and no depressed appetite. Past psych history. AP was diagnosed with and medicated for depression and anxiety with unknown agents when she was 12 years old. The patient reports that she quit taking the medication only after 3 months. AP denies any hospitalizations or serious events related to psychiatric illness. No forensic history. Family psych states that father and maternal grandmother were both severe alcoholics, though it is unknown if formal diagnoses were ever made. All the other immediate families have been described as non-users and very supportive of her decision to end cannabis use. Substance abuse history includes 14 years old. She began using marijuana, alcohol with friends, boyfriend at the time. Soon after, she became using methamphetamine, experimenting with cocaine. She reports not using cocaine regularly and was able to cease use without help after approximately 1 year of use. AP reports using Vyvanse and Alderol for a short period of time during the summer of 2015. Despite the use of other drugs in an abusive manner, her predominant addiction remains marijuana. Okay. Medical history: prescribed unknown medication, treat depression, anxiety, work life. Throughout her time of drug use, AP maintained job as caregiver, home medical service. However, 1 year ago, her assigned patient passed away and she was not given any new patients. This precipitated an increase in her drug use. Social history: born in a mid-sized city, raised in an adjunct, more rural county. She is the oldest child of a family consisting of a biological sister and an adopted brother. She reports not getting along with the sister, but getting along better with the brother. Her mother divorced her father when AP was probably 3 years old. The reason cited by the patient for this divorce was a severe history of alcohol abuse. Mother remarried soon thereafter and remained with the second husband still currently. AP does not believe this separate had any profound impact on her drug use. She states that mother never drank or used drugs and that her stepfather hardly ever drank, and she did not have much interaction with her real father because of the shielding from her mother. In adolescence, AP met her first husband, began using marijuana socially with him. He also introduced the cocaine, methamphetamine. Because of her drug use, causing her not to give a blank, the continued pressure from her first husband to increase drugs, AP dropped out of school. She was forced to move in with her first husband due to her mother being not happy at all about her decision to leave school, which was eventually remitted when AP obtained GED at age 16. Period of cohabitation with first husband led to increased use of marijuana, methamphetamines, cocaine. Eventually, AP, however, became tired of it and did not want to escalate her drug use to substances like heroin. Because her husband at the time was escalating to heroin and his sister was the provider of marijuana, AP decided to split away from him and take their 2 children with her. At that period of life, after the first divorce, involved decreased use of marijuana and methamphetamine, cessation of cocaine. She reports finding a job as caregiver. During this time, eventually met the current boyfriend. With the current boyfriend, AP reports that she use again decreased due to non-acceptance drug use. After her long job as a caregiver, however, her use increased due to stress and lots of problems developed between her and boyfriend. These problems ultimately led to AP admitting in a group therapy session her boyfriend had become both verbally and physically abusive. On admission, AP was feeling scared of her withdrawal symptoms and ashamed of her increased drug use. Due to the loss of her job and inability to find a new job while in treatment at this facility, AP reports lots of stress over financial consideration. Her premorbid personality issue. Prior to drug use, AP describes personality as incredibly shy. She states that both then and now she suffers from a large amount of social anxiety. And its predominant factor in her use and cravings. Self-reported anxiety is also cited the reason for her to begin use initially. AP also stated that she is easily stressed by completely normal stuff, and that this too is a contributor for her drug use, and it was the best thing she could find for her stress. When questioned if she believed her family history could have been a contributing factor to her development of a premorbid personality, AP denied any contribution and states that she believed it was just the way God made her. Physical exam, she's 5'7", weighs 182 pounds. Respiration, she's alert ×4. Physical electrolytes were in normal norms. There were no particular abnormal findings in her MMSE. She seemed, at the time of the evaluation for mental status, she was well-dressed, clean. So here we go. All right. So what's wrong with her? What's her DSM-5? What kind of problems does she have? Cannabis use, cannabis bothered, meth use, cannabis use disorder, severe stimulant use. Okay. Mm-hmm. Mm-hmm. Okay. Mm-hmm. Okay. All right. So for you that have reported, I've got her down as a F1220, cannabis use disorder, severe. Some of you have included a meth use disorder, moderate, marijuana. Okay. Kept going to use severe. All right. So we got it. What level of treatment does she need to go to? What level of treatment does she need to go to? Joel, we're going to talk about childcare in a minute. IOP 21. 21. 21. 9 and 12. Jason. Inpatient. That's interesting. Okay. Residential. Janelle. Okay. All right. Y'all coming. All right. Let's see what we got. We have severe cannabis use disorder with withdrawal, which most of you got. We also have a moderate amphetamine use disorder, which some of you got. The management issues are the management of marijuana withdrawal and amphetamine withdrawal require day-to-day monitoring. So we're going to have detoxification services. So you're, as I've told you, you have levels at 2.1, 2.5, 3.1, 3.5, 3.7. So that could be a applicable, reasonable thing. We have to assess her psychiatric history. Doesn't seem to be, except she says what though? Y'all pick up on this? That she's extremely shy. What and anxious. Well, what does that extremely shy indicate to y'all? What do we need to do about that? What is something? There's definitely a social phobia present. There is. CBT, I agree with that, Janelle. Is that something that needs to go along with the treatment of why she's in the treatment that we're with? Okay. Okay. Because this part of this management component, this management plan component that I'm showing y'all, it says regular assessment of general status. That's one of the things that we need to do. And there was, I can't remember, there is actually an evaluation tool that has to do not only with anxiety, but we also have one that actually has a shyness scale. I can't remember if it's Coleman. I cannot remember. I use that a lot for several years. But anyway, but when we sat down and talked to her about her struggle, see the problem with her, and there's two things here that is not reported. She's got 3 children, right? 3 children. And she used during all 3 pregnancies. And she has 3 special ed children. They're detrimentally impaired. Well, yeah, you're talking about DCF, if you're talking about DFACS, we had to report it. I mean, it was obvious that, and it was not just having to do with her. It had to do with first husband, had to do with current situation with the physical abuse. So she was having severe, significant withdrawals from cannabis, secondary withdrawals from amphetamine. She was having anxiety and panic attacks that she would call severe shyness and social anxiety, that she couldn't sit still in group, because when she started to wake up and you would look at the children, you would know that she would see what she had done to those children. And there's 3 of them, y'all. There's not 1, 2, there's 3 of them. And so um, so the problem is, even though we talked about it and it's not talked about in this report, and that's the one thing I had to go down and when this was given to me and we redid this, she had to be reevaluated. And this time we wanted to talk about, and this was a couple of weeks while she was in treatment, while she was with us, while we was trying to decide where we were going to put her and what we were going to do with these children, what was we going to do. Yeah, the father too was using. It's like not top notch. Yeah, I agree, Jeanette. It was lots of problems from the developmental standpoint. But when we talked about this premorbid personality, well, that part of that premorbid personality came from an overwhelming shame and guilt that she had as being using marijuana and meth during pregnancy, which are some of the worst that you could use. One had a cleft palate, not bad, but very repairable. But we had slow cognition in the youngest one. And the oldest one was hyperkinetic. And so when all of that started to come about, it was, one of those things, what do we do? And so I'll have to give the mother, I have to give her what she said about her mother. It's true. I have to give her mother and stepdad, they stepped in. They didn't know all of this. They didn't know all of this. They didn't go to foster. They went to her mother and her stepdad, Rebecca. But that was a big deal because she had to acknowledge what she had done. And the mother, which I have to give the mother the greatest credit, she had to tell her mother what she had done to her children, which is always a huge issue when it comes to effective treatment and therapeutic change in this individual who had living with this tremendous guilt. And that's why I perpetuated her use, until the use stopped. And she looked at it and she could look, and you could look at the children and tell you, oh my God, look, what have we done here? But the thing about it is they went to the mother and the stepdad. And so what we did was another one of these, because of that, we stabilized her and did detox her. And then we referred her to a long-term women's program that once we were able to stabilize the children at the appropriate time within an 8-week window, once she was there 8 weeks, she could bring the children and she could live with the children while they were there. And to this day, she's done very well. To this day, she's done very well. So, you can, but there's moments, and I guess the thing that I look at when I look at cases and people, and what makes me so thrilled about being in this industry is that we do have those stories. As tough, I'm telling you, as tiring and as tough as they are, and that's why I'll say this to y'all, and this is not to blow any smoke, but I and what y'all do in the world of mental health and helping people and what you're doing now and all the training you went through, y'all are saints. I mean, y'all are literally saints to be able to do what you do. And that's why I work with you. I'll be honest with you. That's why I work with you. That's why I do the things I do for folks, to get you down to another level, because I've got to have y'all at that level in order, in case I know some of you won't do this, but a lot of you are planning on doing it. In case somebody does have to have a medication, y'all going to be able to do that. And that's one of the things. Yeah, I know they don't call you saints, Joey. They don't call you nothing but asshole and jackass and blah, blah, blah. Yeah, I understand. But, I'll call you that because that's one of the things that I think you need to hear. And a lot of people need to hear that because y'all wouldn't be doing it otherwise. I don't think y'all would be doing it. And I wouldn't be helping a person like this. I mean, but the thing that I've learned, y'all, and this is one thing I'll pass along to you. Patience is the greatest teacher. And this particular case, everybody want to jump. Well, we had to stabilize her first. But the thing also, we had to do something with those children. Either that or it would have gone, you're welcome, Angela. But they would have gone to DFAC. And Lord, that would have been worse. It'd been bad. I don't know about DFACs in y'all's states, but in our state, it's not. foster care is not the best, especially in this region. So anyway, and maybe it's just I've had bad experience with that, but I don't know. But anyway, what we did with her is that we sent her off to a women's residential program, and she recovered, and she has done well ever since. So I'm very grateful. All right, let's see if we can do, maybe get one more one in here before I have to leave the building. All right, let me do this to this too. All right, I want that one gone. Let's do let me see what this one is. All right, let's try this. This will be our last one, and we'll end at whatever we do. If this goes to 7 o'clock, we'll end at 7. I'm not taking y'all past 7, okay? So let's see if we can get this one done. Here we are. All right, here we go. All right, let's see what we got here. Now I'll try to abbreviate this. This is a 27-year-old Caucasian female, drugs of choice, has a boyfriend of 11 years. She has comorbid opioid and benzodiazepine use disorders. She reports that her mother's therapist recommended treatment. Mother researched and inquired, and they decided she would come to treatment. She presented in January of 2016, said, I have a problem with oxycodone. She reports approximately 6 to 10 tablets of 30 milligrams oxycodone a day with 3 milligrams of clozapam. She reports crushing and snorting the oxycodone during the oxycodone use. It's about 3 years. She reports using only clozapam at high doses for at least the last 3 months. Acknowledges taking prescription clozapam twice a day for the past couple of years. Although the patient reports a history of abuse of illicit substances, she denies any other use besides oxycodone and clozapam at the present time. She has spent over $2,500 every 2 weeks for her addiction. The stress accompanied the potential to kick her out of her parents' house, combination of catalyst HF to seek outpatient assistance. Initially, she's fidgety, depressed, and restless. She reports GI symptoms, including diarrhea and cramping. She includes, in addition to the patient use of hydrocodone, she has extensive use of other substances, dates back to her early teens. Regarding opioids, she initially used hydrocodone, acetaminophen, progressed to oxycodone, acetaminophen, eventually to oxycodone 30 milligrams, where she began snorting. She says she'd been buying her own drugs and stealing them from work. She reports spending $40,000 on drugs. Reported a fear of losing everything that drove her to seek treatment. Okay, all right. Initial vision, she reported fleeing suicidal ideation, no planned means or intent. Reports desire to live despite arrest and treatment. Of course, she denied suicidal, homicidal ideation or intent. Reports risk of suicide in distant past when she cut herself at 13. She's been alert, oriented to person, place, time, and situation. Has no identified learning disabilities, cognitive impairment, or memory impairment. Vegetative signs, moderately anxious and guarded, moderately fidgety and restless, having moderate difficulty with concentration, reported complete loss of appetite. Has some difficulty with sleep throughout treatment. They may be improved. Most recent assessment, patient reported only main anxiety and restlessness and agitation. Past history, has a history of depression, psychiatric history. Diagnosed made 5 years ago, generalized anxiety. She's been taking Lexapro 20 milligrams and has been efficacious. She promotes clozapam 0.5 for anxiety and claims that she's had an active prescription for approximately 2 years. However, she reports only using it as needed, not on a regular basis. According to patient, the clozapam intake increased to significant in December when she was utilized up to 3 milligrams per day as a way of coping with withdrawal. No forensic history, been using since the age of 13, multiple opioids, smokes 1.5 packs of cigarettes a day. Now she was vaping e-cigs. Denies current alcohol use. History started with marijuana at 15. Used ecstasy, LSD in her early 20s. Adderall started in November 15th of 2015. Methamphetamine use in 2016, only used 3 times. Family history significant for half-brother who is an alcoholic and addicted to opioids. Both grandfathers are alcoholic, maternal uncle alcoholic, maternal aunt is recovering from methamphetamine addiction. Patient's mother suffers from depression and anxiety. Patient also reports history of suicide on her mother's side. However, she's unclear of the specific details. She has a history of palpitations in her early 20s, well controlled with metoprolol, succinate extended release, Lopressor, for you that may not know that, but it's it's a beta blocker. Patient is also treated for depression, which she's been prescribed Lexapro 20 milligrams, 4 to 5 years. She has a bachelor in nursing, been working in the ER at the local hospital, comprehends further education and wants to be an NP. Social history, lives with patient, still married. Patient has half sister, half brother, father's children. Patient perceived parents' relationship as angry and characterized as great deal of arguing. During her childhood, she witnessed her father emotionally and verbally abuse her mother. Reports being a victim of verbal abuse by the father. Reports her mother would send her to stay with other relatives for months in order to appease her father, who didn't seem to want her around. HF reports feeling abandoned, and though she was never fully wanted by her father because of her theft in order to support a drug. Her family is mistrustful. However, they continue to be enabling, and as a result of that, she reports family unaware of duration and drug use in the current living environment. There are no alcohol and drugs in the home. Parent reports enjoying hobbies of television, crocheting, etc. All right, let me go with premorbid and get to, and then we'll talk about what we need. Premorbid, she's anxious, depressed, prone to worrying, labels herself as an introvert, potentially has attributes related to relationship with a father, and 5 years ago, patient had occasional use of clozapam until a few months ago, etc. Okay. Physical exam showed that she was 193. She is 5 foot 11 and 193, so she's BMI is 27, which she's a little overweight. Physical exam, no particular issues with that. Mental status, orientation, mental status, has anxiousness, regards of, I've been told it's a choice, why can't you just stop? Okay, all right. With that said, what do we got? Tell me what y'all's impression is. Opioid, severe benzo, severe detox, 3-7, opioid, benzo, opioid, severe anxiolytic use, severe opioid use. Okay, okay, okay. Opioid use, severe. Okay. Nicotine, severe. Appreciate that. Okay. All right. Let's see what we got. DSM-5 diagnosed HS follows severe opioid use disorder, F11-2, opioid withdrawal, F11-23. She has severe sedative hypnotic anxiolytic use disorder, 13-20, and severe, or she has sedative hypnotic analgesic withdrawal of 13.239. Now, in this particular one, in this particular case, when I put this down, I actually broke out what we did and what happened and what should happen. And this is another way that you can put in your criteria and doing that. So this was the first one that had to do with the opioid use disorder, and which criteria she met. This second one was the withdrawal and which criteria she met with that. The third one was the sedative, severe anxiety disorder, and what we did with that use there, and then sedative anxiety withdrawal, what we did there, use there. So, all right. And I got 5 minutes. So with that said, and I got an incoming call from my son, so I'm going to put him on hold. Questions, comments? Y'all understand what you need to do for your 5 cases? Just write them up, submit them to Moodle, and it has a way that I can grade them. This individual would go to 3.5. This individual would go to 3.5. Well, you say, do they have an extensive as yours? No, Janelle, only 5, the first 5. You do the first 5 cases. Yes, we can. Please, all I want you, what I'm trying to gather, y'all, what I'm looking for is, one, you understand the criteria, which you should. You understand the mild, moderate, severe. You understand what level of care you would recommend and the reasons for that. You need to also, when you put down your severe, moderate, or mild, I want you to put down the criteria that your case meets as far as what you see in the case, okay? And that way it gives me a sense that y'all know what you're doing. You know what you're doing. And I grade it that way, and we'll go on about our business. 1 to 5. 1 to 5. Cases 1 through 5. Okay. Y'all can do all of them if you want to. I mean, if you want, you know, and send them to me if you want to. I will not object. 1 through 11. That's correct, Eddie. Numbers 1 through 11. And you can put them as listed, you know, in that handout that I sent you, you know, the DSM-5 diagnostic. You can put them according to that. And then just put down the reason if you see it, you know, tolerance because of this or that and this and that. And there you go. See, by the time I get all of you together, by the time I get 24, 25 of you together, I will have one core of you know, for each case. And that'll be great. Because the next time I do this, then I'll have answers for them to be able to provide the same thing, and hopefully this will help. So, yes, Rebecca, my goal is, and I've got to work this out, that once I get a score, once I get y'all's in there and I give you a score, I'm anticipating that we'll be able to give you extra points on your exam. And I've got to work out how we get that. I don't know if I grade it or, you know, I got to talk a little more about it, how we do that, but I'm going to make sure you get credit for it. Okay. Or your final exam will only count a certain percentage, and this will count a certain percentage. So if y'all make, let's say if y'all make 25, you know, this counts as 25% of your grade, and your exam counts 75% of your grade, and you make 100 on this, then you understand what I'm saying. I'm going to work it out. You know, I do that all the time, so we'll be able to work this out for them. Okay. Well, I've enjoyed it. Y'all have been a great class. I'm excited about it being done. No, we've had a long 2 days. And but thank you for being so amenable and timely, professional, and I hope this has been beneficial to you. I hope it has. I hope it has. Because if I find out that it doesn't mean that much or doesn't help you, then I'll probably not do it again. So, but I appreciate it. So, but y'all have a good evening, and let me see. Aiden, are you there?
Yes, doctor, I'm here.
How you doing?
I'm good. Thank you, doctor.
Well, good. I'm going to get this stuff up. I probably won't do it tonight because I've got a call from my son. I'll send it to you starting in the morning. And then I'll probably want to talk to you about what kind of credit I want to give them for these cases they're going to do. So we'll discuss that if we can.
Sure.
And then we'll see if we can work it out. Okay?
Thank you.
Thank you.
I'll probably be on a road until like 11:30 or something.
I got you. I got you. Well, I'll text you or do something, and you just get back with me when you can, okay?
Sure, doctor. Sure.
Thank you. And thank you for your help. I appreciate it, Aiden.
Okay.
Have a good night. Thanks, everybody. See y'all.